Uh, I will present two short cases. One, I landed in trouble. One is a textbook case. So this is a 59-year-old, a 73-year-old lady from US. She worked all her life as a cardiovascular technician, so refused CABG. Her RCA was dominant. I did a angioplasty to the RCA. This is the left main with a bifurcation lesion, extensively calcified. Wired both the vessels and tried to get a microcatheter in. It wouldn't go beyond the initial part, so I pushed the microcatheter as far as I could and exchanged with a rotor wire. This is a slightly wrong run, please bear with me. The rotor wire was passed and I took off with a 1.5 burr. So you can see that the LAD is jacketed or practically throughout the thing. So first few runs, I just managed to open out the proximal most part of the LAD, left main into the LAD. Successful. So decided that let's push a little further ahead and see what I can do. This is a fluoro loop, so it'll take a few minutes before it starts playing. So the second run was much better. It crossed all the obstacles I thought was there. It went off. The run was going very smooth. But you can see that there's a slight wobble in the burr as it came back, and then it refused to come back. Retrospectively analysis, I could make out that there was actually a calcified nodule at that area. The burr has got slipped up and got stuck under the calcified nodule. So this is how it looks. Luckily, the angio showed that the circ was flowing, a little bit of angina, NTG, all the vasodilators possible. The two options I had, first is a famous mechanical option, try and pull it out. Otherwise, I would have gone for a ping pong. But with a little bit of, you can see that the guide is buckling. But eventually, the calcified nodule decided that, okay, I will let the burr off. The burr came out. Whole system came out. Rewired. Only problem was, if you see carefully, there's a dissection at the ostium of the LMCA, aorto-ostial junction. And you can see that there is a dissection and the dissection is getting filled. So now the option is between surgery and somehow packing up a stent in the proximal LMCA so that I can manage to stop the progression of the dissection. So the wires are rewired, dilated whatever I could. Again, the flow was there, but the stent I took was a 3 into 29 millimeter stent. It just wouldn't go beyond the mid of the LMCA. So the dissection is still there and it is not looking very good. So this time I took a chance, took a 3 into 12 IVL balloon, dilated 40 pulses in the ostium of the circumflex and the ostium of the LAD, that junction, and the rest of the pulses in the proximal part of the LAD, left main. So following which I could dilate well with a 3.5 balloon. Then I passed a 2.5 balloon into the circumflex and dilated the circostium. Decided that under the circumstances, with the present luck I have, I should just go for a provisional stenting. So I stented with a 3 into 29 alpine from the left main into the LAD. Luckily, it went in and it expanded. Pot again with larger balloon. Final shot, there is no leak and the LAD and circumflex are flowing. So I stopped the case at this stage, decided that in case she develops angina, we'll call her back. This was done on July 1st. Next 2 reviews has been done. She's holding on. I'll quickly go to the second case. This is again a gentleman who came to me with STEMI actually, stuttering STEMI. So this was the first shot that I got. So I decided that I thought it was a big thrombus sitting in the left main, distal left main. I kept him on eptifibatide for 24 hours, brought him back the next day. Unfortunately, nothing had changed. So I took a balloon, short balloon, gently pushed and dilated. That thing wouldn't budge from there. So we took a OCT and did an OCT run from the LAD and from the circ. So this is this OCT I could do with saline. You can see that because the 7 French catheter was snug, so I did not. The OCT could be easily done with saline, and we got. This is the post OCT shots. So the OCT done showed he had a mid LAD stent in the past, which came out at this time in his life. He has extensive calcification. You can see that it's 360-degree calcification. And this is the little bit of ISR. And there is proximal significant amount of calcium. You can see some places it's going up to 360 degrees. The stent, there is a growth inside the stent also. Calcium inside the stent too. So after this was done, we took circumflex. There is a huge calcium chunk at the ostium of the circumflex, which is actually what was being seen in the angio as what was thought as a thrombus. You can see that the ostium of the circ is significantly diseased with calcium, and it's a very tight lesion. It's the proximal part, 360 degrees calcium. So we decided that we will go in with an IVL again in this case, a 3x12 IVL balloon. First, circumflex being the more tighter lesion, I used the IVL balloon, the circ first, and managed to. So the problem was again keeping the IVL balloon inflated for 10 seconds to 10 to 14 seconds just to get the IVL on. There was significant drop in BP, tachycardia, but we managed to hold on. So we delivered 40 pulses into the circumflex, and then took the same balloon, went into the proximal part of the LAD and the in-stent. The rest was all very simple. We did a decay crush and managed to stent the circumflex and this is just to show the post-IVL run. Not recommended that we should do a post-IVL OCT run. We just did it for completion. So we can see that the significant amount of calcium has been broken, and the subsequent expansion proved that the IVL cuts have been very successful. You can see that the various cuts showing the IVL has been utilized. Then we went ahead and did actually a mini crush, I think. Not sure. We went in, deployed the stent in the circ, deployed the stent in the LAD to the left main at 3.5, did a pot after that. Pot, recross, kiss, second kiss, pot and out. So we got a fairly good result at the end of the day. And this is the post-final LAD run. You can see that the calcium is still there, but it is opened up in the areas that mattered. We could get a little bit of prolapse, a little bit of tissue prolapse, a little bit of red thrombus. So we did give eptifibatide at this stage. Distal expansion was 100%, proximal was 95%. Mean areas of 7.09, mid was 12.67, and the LMCA was 14.06. So this 5, 6, 7, 8 concept, we need to restudy. We can get much higher areas with these. The bifurcation view shows reasonably well opened out circumflex with hardly any struts across. So just to stress the role of Magen and effective treatment with IVL, one for salvage, one as routine. Thank you.
Congratulations. I think cases were very nice. Anything you would have done differently, suppose you had to do it again? I was thinking, for the first case, anything different you would have done?
First case, probably I think I would have landed in the same trouble again. I don't think, because it is not expected that the burr was going in smoothly. If you see, the burr has jumped up a little bit and got caught inside a nodule.
Right.
Unavoidable. And no balloon was going through, so I had to burr it.
Right.
I had no options.
So I was thinking maybe you could have taken a long sheath. I saw that even after you pulled it out, if you take a long sheath, sometimes the support is better.
Okay.
You've, I think, changed the guide 2-3 times. That's what I noticed. That
No,
it's
no.
gone from JL to EBU, back to EBU again.
EBU.
I saw that it was back
JL
to
was
EBU
what
again.
my optimism started off with. They say the older cardiologists use JL more than EBU.
Yes, yes, even the newer ones use. The thing is that it doesn't provide too much of support in the left main. So it's a
I
good
agree with
idea
you.
to take a long sheath.
So in left main, specifically when I want to do the ostium of the left main, I go with the JL because controlling the guide is still better with the...
Even a DK crush in which you have to involve the left main, the JL is always better. I completely.
That is
and
the-
second, what rota wire was used? Was it a floppy?
Floppy.
or- So
Because
since it was
I
a
didn't want to
straighter-
take an extra step because even microcatheter was not going through.
Right, I mean...
I had to wire it without the microcatheter.
Right, I saw that you've jammed the microcatheter and
Then
wired.
wired.
But when the LED is actually pretty much a straight segment, there
Yeah.
wasn't too much of curve, I would have chosen probably a stiffer wire
Stiffer
because
wire.
it would have made it easier to burr. Otherwise, I think the salvage was fantastic and beautifully done. And second case, anything different?
Second
I
case,
think it was done extremely well.
no,
Superb, really
second
nice.
case, I did 24 hours, eptifibatide didn't work.
No, the procedure itself, I think, was beautifully done. What was the size of the circumflex on the OCT? Was it 3 or 3.5?
No, it was 2.75.
Right. I think that 3 is okay.
Again, very problems of calcium that were handled very nicely. These are, burr getting stuck is something that happens to everybody who does rotablation frequently. So it's something probably that we cannot always get away from. But the complication was managed well, and ultimately the results were quite good. One point is that when you are using the IVL balloon, IVL, it is not mandatory to give all 10 pulses at the same time. So if there is some hypotension or
we
chest
stop.
pain or this thing, we can always stop and then,
In between and then
yes.
And lastly, stuck burr, it was very, very proximal. I thought maybe you could have passed another wire and done a small 1.25
No, I was
balloon
trying to
beside
get the
it.
guide in. The guy wouldn't move in. So if this mechanical thing wouldn't have worked, I would have put in a ping pong method, passed a wire parallel to that,
Right.
did a ballooning and come out.
It was very proximal, so I think it would have been
Come on.
beautifully
Thank you.
managed.